So just to get started, I want to say, as social scientists committed to understanding the complexities of human societies, it's important to begin by acknowledging the land that which we gather. The University of Toronto operates on the traditional territory of many Indigenous nations, including the Huron-Wendat, the Seneca, and most recently the Mississauga of the Credit. The land has been a site of human activity, governance, knowledge exchange, and cultural expression for thousands of years. It remains home to many Indigenous people from across Turtle Island, and we recognize the enduring presence and resilience of First Nations, Inuit, and Métis communities. As we engage in scholarly inquiry, let us reflect on the responsibilities we carry as researchers, educators, and community members to respect Indigenous knowledge systems, histories, and rights.
Welcome everyone to the Reframing Pain Conference. I cannot tell you how thrilled I am to have this day finally arrive. At this particular historical moment, I think it's more important than ever for us to gather together in the work that we do toward equity, toward social justice, and be able to support each other. So PEPR is the project from which CASPR emanates. So PEPR has two main objectives. The first is to bring an equity lens into this notion of patient engagement in research and to really explore both what that does look like and what it could look like. And then the second objective, which relates directly to CASPR, is that we have a mission to advance critical social science approaches in the chronic pain and pain research spaces. We are inter and multidisciplinary. We have anthropology, we have sociology, we have nursing, philosophy, occupational therapy, physiotherapy, psychology, social work. You name it, the disciplines I think are represented through CASPR. So thank you so much everyone for being here, and thank you to all the speakers who've traveled so far to join us today.
Thank you very much. I'm going to talk about my thesis research. I'm just coming to the end of my thesis, so any feedback is welcome before I submit it. So my research idea came from my clinical practice, where I work as a physiotherapist in Lanarkshire in Scotland. I mainly see people with long-term and severe chronic pain from areas of socioeconomic deprivation, and often how people come to terms and how they can come to terms is pivotal in their sort of healing journey, if you like. So just to acknowledge input from my PhD supervisors, advisors, co-authors and researchers, and of course many more, and my PhD studentship funding from NHS Lanarkshire and Glasgow Caledonian University. So my thesis was an exploration of how the concept of acceptance of chronic pain could inform improvements in journeys for people with long-term pain. So I started out with the operational definition of acceptance of chronic pain as per a specific psychological model, set that aside, and then moved into a sort of broader overarching concept. So I'm showing you the conceptual framework of the first study, which is a meta-ethnography of 10 primary studies. So my research question was, what are the lived experiences of acceptance of chronic pain? And I took the position of the phenomena being socially constructed. So I found a fluid and continuous journey for the individual, which has fluctuating states of acceptance, which are shown in the knotted centre. There was also features of iterative steps, of turning points, and of a challenge to identity, which I connected to capitalist and ableist structures and ideology. So conceptualizations of acceptance were related to the language and meaning of the painful condition, and it appears to be a contested concept. So there's also the caring, supportive and coherent systems that promote a positive version of coming to terms and living with chronic pain, and they are represented by the roots of the ecosystem. So just to explain, it's represented by a rose bush containing both roses and thorns, such is the nature of accepting life with chronic pain. So I used meta-ethnography to explore both the thematic findings and the contexts of the primary studies, and by doing so, I showed differences in the concepts of acceptance, so there is no one unified experience. So I then sought to engage two groups of people in further qualitative studies to contextualise the meta-ethnography findings and generate ideas for improvement. So the ecosystem was a very handy tool to generate discussion about social worlds. So the figure is supposed to show that there are multiple versions of the ecosystem, but also realist elements. So at the same time, I was also using the intersectionality literature to inform my methodological development and interpretations. An intersectionality framework guided the next qualitative study. So I wanted to essentially do PPIE work, but to recruit people who might not normally put themselves forwards for research, thus experiencing epistemic silencing. So this necessitated NHS ethics approval, and I sought to recruit people who adversely experienced health inequalities for participation in 3 focus groups and also using diaries. So I recruited 7 residents of Lanarkshire, and I was struck by the severity of the chronic pain, the mental health, and none of the people were in paid work as well. So I found 3 main themes, and this connects to the idea of moving acceptance from the individual into the systems around them. So the first theme here is unaccepting, disconnected and dehumanising systems, and the dehumanising descriptor was particularly applied to the social security system in the UK. So the first example here shows somebody internalising societal attitudes. So if anyone asks me what I do for work, I just say I'm a bum. I mean, I don't work, so that's just how people will see you anyway. You just belittle yourself so that other people don't do it. The next one shows the stress associated with the social security system in the UK. So you're on the phone for 2 hours with someone you've never met, doesn't know you, they're ticking boxes, like my anxiety. I didn't sleep in the run up to it. I felt as though I was having to prove how much pain I was in every time I was on the phone. It's a stress. You feel as if you're begging for money to live. And then conversely, there's the connected, understanding and accepting systems. So to illustrate, I finally got a good doctor who actually listened to me. So having that support system from somebody who's willing to listen, they know more about it, they understand it, they are willing to accept it. And then there was individual variations and experiences in the journey of coming to terms. So I also conducted a further qualitative study using World Cafe with 25 interdisciplinary staff who deliver care in Fife, which is a region of Scotland. So I gathered different types of qualitative data, some of which is showing here as the wall summaries, and there were different levels of findings. So there was 4 main themes. So the first one was that the ecosystem validates the complexity of the overarching accepting journey to staff working in clinical practice, and there was value that they found in having this visual representation of complexity. So there was also recognition of the role of socioeconomic factors and disadvantage. However, there was less ideas over what to do about that. Dominance of the biomedical model was seen as a barrier to accepting and moving forwards, and then providing the roots of the ecosystem was something that staff saw as their role. So they discussed ideas for developing long-term connected and relational pain care in Fife, which are shown in their version of the ecosystem. So you can see the qualities that they discussed and generating ideas for improvements about to their service. So there was also features of stigma, shame, trauma, and interactions with the social security systems again that came through as features of this ecosystem. So in concluding my thesis, I've drawn all of the main findings from these studies together, and one of the most important conclusions, I think, is that coming to terms with long-term pain is a complex process. So the so-called softer and relational skills of care play a vital role, but care needs to be structured and adequately staffed to adequately provide space for the softer skills of care. So it needs to enable and accommodate for turning points, fluctuations, and the long-term nature. So I have combined my main findings into this is like the final ecosystem. So at the micro level, each of these represents a feature of the findings across the qualitative studies that is particular to the individual. So we have mental health, the nature of the painful condition, the severity of the painful condition, and health literacy. At the meso level, there's targets of change that could lead to improvements in the chronic pain journey. So they include workplace adaptation, health literate organisations, trauma-informed approaches. And then on the lower aspect of the meso level is biomedical dominance, under-resourced services, and disconnection. So at the macro level, I placed caring and inclusive economic models, which is an area that I've sort of gone further into, which is quite a hot topic in Scotland just now. And that's countered by sources of marginalisation, stigmatisation, and inequities, another hot topic in Scotland right now. So there are 4 sections that cut across levels in the figure, and they represent concepts that are implicated at all 3 levels. So social security, for example, occurs for the individual. It's also a function of the state, and it's also influenced by societal discourses. So just the final point that I wanted to mention was that applied health research, particularly the stuff that I'm reading in the UK, increasingly recognises the role of context, macro and institutional factors, and I think that critical approaches and interdisciplinary working play an important role in facilitating the field and moving it forward.
All right. Thank you for inviting me and for being here. I'm really excited. It's lovely to be here. And I'm going to do a small overview. Hopefully some of you might be at the conference tomorrow or the next day, where I'll be talking in more detail about some of this. But I think it's really critical that we talk about and think about the effect of structural inequalities, particularly mechanisms of injustice when we think about those for individuals from Black and brown communities. And so this is a paper was a few years ago now, published in Pain. The first author is one of our colleagues, Vanni Mather. She went to a dueling conference in the US, so she's at USASP, but I'm happy to speak her name here. And we worked together to think about these mechanisms of injustice. So essentially, that individuals with pain outcomes have to work through a myriad of injustices to seek pain care. And as currently, we do lots of work here in our individual processes, right? And as many of you know, as you see the papers that we publish, we do a little bit here, but we've done very little here historically. We have some wonderful scholars who've been working at this for many years, but they have often been working in isolation with little funding to be able to do their work. Even though individuals sit within all of these mechanisms of injustice. And I talk about these mechanisms. This is quite a flat figure. I loved Cassie's beautiful figures, and so. But as we see through here, I often try to think of this as that we all have to make our way through here. And so sometimes I think about it as sort of a lake or a soup even, right? And we have to, some of us get a canoe, some of us get a paddle, some of us get nothing. And we still have to make our way through, and we're all only focusing here and not thinking about here. Social justice is a place where we have to sit in some discomfort. And so I was lucky enough to attend a talk from Dr. Kamara Jones. She's one of the scholars, a public health scholar who's been working in this area for many years, sort of outside pain, but thinking about social justice in public health. And she said she used to give these talks, and she would say at the beginning, I'm going to make you uncomfortable, I'm sorry. Like she would be like, and then realize that no, we have to sit in discomfort. We have to, that's the only way to move forward, right? Because if you're sitting comfortably and you're happy with things, then you're not going to want change. And so the only way to move forward through social justice is through experiencing some discomfort as individuals next to you, your neighbours, the people you live around, are already experiencing that discomfort. So I ask you to join me in sitting in that discomfort today. As was mentioned, my research focuses on children and young people living with sickle cell. Sickle cell, for those of you who don't know, it's an inherited blood disorder. In every room, even in a smaller room like this, I will always say it is the most common inherited disorder worldwide, and there were people in the room who won't know that. And I think there is a reason that we don't know that, and it's because of who sickle cell affects. The other thing I always want to say about sickle cell, it is not a disease of color, it is a disease of ancestry. So individuals who, where sickle cell disease is most prominent in Africa and the Middle East, have darker skin color. In those areas, malaria is endemic, and having the trait, so being a carrier of sickle cell, was protective against malaria. And so that's the reason that the trait continued. And so it is a disease of ancestry in which unfortunately, if there are challenges in pain, and if there are challenges in pain for individuals of colour, then those become multiplicative for those living with sickle cell. What I'm going to talk to you most about today, and as I said, I'll expand upon more tomorrow, is a concept called racism-based traumatic stress. This is not a new concept. It's been for many years. But for those of you who don't know, it's significant emotional and mental injury caused by frequent, uncontrollable, and that's the key piece, racist experiences and encounters as stress-inducing with the potential to produce traumatic responses. And so what myself and some colleagues wanted to do was think about racism-based traumatic stress, or RBTS, in the context of pain. So that's what we did. The restorative model looked at RBTS and pain as it had not yet been explored. And the restorative model is racism exposure and trauma accumulation perpetuate pain inequities, and we're advocating for change. And this is a novel conceptual model that integrates the models of racism and pain and demonstrates how we have this shared contribution of trauma symptoms, and that maintains and perpetuates chronic pain for racialized groups. So this is the restorative model. Some of the colleagues, so our fellow panelists and some others are part of this group. Also multidisciplinary, so we are psychologists, both research and clinical, sociologists, anesthesiologists, physiotherapists, epidemiologists. We really wanted to think about this from a critical, larger lens than we normally do in pain. And so this is our model of pain, right? You see our biopsychosocial, right, what we're used to. But we also think about these structural traumas, environmental triggers, and generational traumas. And then when we said, well, let's look at our model of racism. Oh, wow, there's bio, psycho, social. We have these structural, cultural, generational racism, right? Those mechanisms of injustice that we all sit within. And we're saying that trauma symptoms, be they more PTSD-like that we've been studying in pain for quite a long time, or be they more RBTS-like, come together to create these trauma symptoms. And that is one of the reasons that we see chronic pain inequities for individuals of color, particularly those from Black and brown communities. And seeing that we focus on those individual processes, right, those individual outcomes that I mentioned, and we discount our intersectionality, and we haven't done enough to consider that. But we do think there's a pathway to restoration, even during these challenging times, and think we can work for pain equity as we first even just acknowledge that this pathway exists and then work to make change. So one of the tenets of the model is cultural humility. When I was trained, so I'm a clinical psychologist, I was taught cultural competence. And I talk to my students a lot about this, is that cultural competence was a great foundation. We needed to start talking about culture, right? But the challenge with cultural competence is the suggestion that we can become competent in somebody else's culture and somehow sometimes maybe more competent than the expert sat in front of us, right? And so it's not actually a possibility, and I suggest it's not something we should be striving for. Cultural humility takes that next step. It says, particularly for me, if I'm thinking about myself as a psychologist, I sit here with the expertise in mental health and psychology, and you sit there as the expert in the lived experience of you, and both of those things are equally important. And we know there's a power imbalance, but let's acknowledge it. Let's work together, right, to make that power imbalance less. And so through a process of openness, humility, self-awareness, and mutual empowerment and respect, we can work towards the outcome that you want. Where would you like to be within the next year? what would that look like? And how can we work together to do that? And it's a process wherein it's infinite and centered on an iterative approach with self-reflection and self-evaluation. And just one story, when I do present this a lot to students in clinical care, and I am always encouraged by our trainees because lots of them come up to me and afterwards and go, Anna, isn't that just being a good person? And I'm like, yes. All right, so one of the things we're also doing now is thinking about adverse childhood experiences. So many of you are aware of those. 1/3 of the mental health problems in adulthood are caused by them. And so if we think about sort of we've got abuse, neglect, and household dysfunction. However, myself and other colleagues have really been working on thinking about that these are just the surface level ACEs. And we haven't been taking our time, and our co-panelist, Star Booker, always puts it best. These are in the groundwater. And we need to start thinking about our groundwater ACEs, right? Poverty, discrimination, community disruption, right? All of these things that play a huge role in individuals' lives. And again, we haven't been thinking about within pain. And so what we know is from recent research looking at National Children's Survey in the US, is that if you've got the bar for white children in white, black children in grey, and then black children who have experienced discrimination in the dark black. And so whenever individuals tell you, well, there aren't that many differences between black and white children, or this study looked at this and this study looked at that, and there wasn't a difference, I say to you, did you look at discrimination? Did you measure racism? Because there should be no difference between a black and white individual, right? Skin color is, and race is a social construct. What happens because of skin color. Right? And so we see that for almost every single ACE, there's 2 to 3-fold more challenges for individuals. And so we are also seeing that in pain. This is a senior paper from Tanya Palermo's lab, and seeing that there's discrimination. And so that's our plan next. We're taking some of these large data sets to show that the restorative model exists, and then taking those next steps as to how we intervene on structural levels. All right, so we're looking at the ABCD data. That's a pediatric data set, and we're starting to incorporate how do we incorporate RBTS into our research. I thank you so much.
Okay, so I'm going to go through my slides pretty quickly. I'm not sure if we're on time, but I want to get us back on time if we're not. And I want to talk a little bit about models of pain in African Americans, older African Americans, and really talk about the need for understanding pain from different perspectives and lenses. And so, one size does not fit all. Chronic pain is different in all people. And so we really have to start to kind of reconceptualize how we think about pain in different populations. These are my funding disclosures. And let's get my timer going. Okay, so in the United States, we are essentially a nation under pain. So over 100 million people have chronic pain. And then when you look at who has high impact chronic pain, about 21 million people have high impact chronic pain. And older African Americans are one such group who are at highest risk for experiencing high impact chronic pain. And when we look at how people navigate the healthcare system, typically we have 2 different groups. People who utilize the healthcare system, and then people who are outside of the healthcare system. And there are different pathways for each of these different groups based on their social determinants of health, as well as other demographic factors that impact how they are able to interact with the healthcare system, but also with other people who have chronic pain. And so this is a figure from the Institute of Medicine report that came out in 2010. And they present this kind of picture of pain. So showing these different pathways of how people kind of interact and navigate different systems. So one of their key kind of, takeaways from that report was that there's a need for a cultural transformation in the way that pain is not only viewed or perceived, but also how it's treated. And so some colleagues and I really started to kind of think about, well, what does that mean? And so we said, okay, Well, we need to reshape kind of the conceptualization, but also how we operationalize pain theories so that they are more applicable to people who have diverse demographics or experiences. And so we've made several recommendations to kind of like further the dialogue. And so one of those recommendations, kind of the broad recommendation, is to reshape the traditional conceptualization of pain and operationalization of pain theories in ways that are relevant to diverse populations. And then we started to say, well, what does it actually look like, right? So we need to reshape our thinking, which means that we start to look at these layered effects of multiple bidirectional social determinants of health. And so within that, there are even kind of more action items, okay? And I'm gonna focus on 3 of those. So the first one is, we need to start to explore what I call the experienceome. So really looking at people's lived experiences. We hear about the microbiome, metabolomics, but what about people's experience, their real life daily experience? We need to really start to look at that further. And then we need to look at how do we apply intersectional identity approaches, and how do we form different intersectional matrices in real time. And then we also need to start to look at more culturally luminescent theories. So really looking at theories that really derive from research with different populations to come up with these new models. And I think Anna talked about the restorative model, which I really love, and I reference that a lot, but it's a really nice model to look at a lot of different factors, including trauma and racism, but we also need to look at more culturally specific theories. So how do we do this? So first, we need to really think about changing the public's as well as researchers' perception, knowledge, and understanding of pain. So I want to just kind of give you some food for thought on how we start to kind of shift that narrative, right? So chronic pain, over time, was conceptualized as kind of being like a singular syndrome, but now we have research that shows that it is a multi-system chronic disease, okay? And chronic pain is not a symptom per se, right? It's a disease state. And then oftentimes we look at the progression to disability and we look at disability as the outcome, but we really need to look at the process of becoming disabled or that disablement process. And then we often look at or think about the experience of pain as a personal experience, and it is personal, it's subjective, but it's also, in older African Americans, a metapersonal experience. So, exploring the experienceome to identify sociobiologic determinants. So one of my research participants, when I asked, I said, well, what is pain? What does pain mean to you? And he said, it's a Down syndrome. And I didn't really understand what he was saying because I've never heard it, I guess, explained that way. But essentially, he was trying to say, it's an experience that essentially it downs or it affects every part of your being, right? Your physical being, your mental being, your spiritual being. It's just a Down syndrome. And so when I started to look a little bit further into, what is contributing to this Down syndrome, right? So looking at this from not only just the kind of intrapersonal, but also the interpersonal and then the extrapersonal. So this is a early version of a conceptual model on the metapersonal experience of pain in older African Americans. And so again, it's not just an interpersonal experience, right? But it's also how do they navigate and interact with providers, with their family, with friends, or with other people with pain. But also how they interact with kind of higher or divine power or God. So that's the extrapersonal experience, right? So there's kind of these 3 levels of experience. And all of this is influenced by historical events their childhood and life experiences, their social support and societal norms, as well as their socioeconomic well-being. And all of this kind of leads to this metapersonal experience of bearing the pain. So when we think about, kind of the historical influence of pain in older African Americans, or just in African Americans in the United States, their experience is really characterized by not only physical pain from chronic pain, but also the emotional pain of oppression. So from slavery all the way through Jim Crow to now we're in this anti-blackness or this black erasure era. And so all of this really becomes embedded and it changes the epigenetics. And I wanted to put this quote in here to kind of demonstrate the historical impact of pain in African Americans. And so one participant says, "We don't want no one to know. We can't blame that on self though. It was instilled in us, because if you think about it, back in slavery, they had to do what they had to do. They had to hold it in order to survive. We can be at 99, we can be in pain, but we know we got to do the job so that we can take care of our family. We're going to suffer through this pain. We ain't going to let nobody know it. Back then, your grandparents and parents, they didn't tell you if they was in pain or hurting neither." So she kind of pulls in how these, I guess, normative behaviors developed over time, right? So during slavery, you couldn't speak up about any problems that you were having. You just had to bear it and deal with it and do what you had to do to survive, right? So even if you were in severe pain, you just had to deal with that, right? So now we need to kind of start to look at these intersectional identity matrices, right? So looking at all of these different identities, how they intersect, how they interact with each other, and then thinking about how does that influence a person's experience of pain. So I like to think of intersectionality kind of as like these layers of identity, right? So you have these different layers, whether it's age, race, sex, your occupation, religion, all of these different things impact how you not only see the world, but how the world sees you. And sometimes these layers of identity can actually increase your risk for marginalization, but it also increases your risk for chronic pain. So when we think about these layers, we also have to think about, what happens when you experience bias in pain care due to these layers, right? How does that impact the progression to disability? So moving on to kind of the third action item, we need to start to really ground our research or our scholarship using theories that are applicable to the populations that we are studying, right? So when we think about African Americans, I've listed a few of these different, you can call them conceptual models or theories or both, including John Henryism, Sojourner Syndrome, post-slave, or I think it's post-traumatic slave stress disorder, minority stress theory, weathering, and I included the restorative model. It's kind of broader. It's not specific to African Americans, but it includes a lot of those factors that are integral to their experience. So kind of concluding here, where do we go from here? So in 2020, ISP kind of made some revisions to their definition of pain. But as we really think about, is this really applicable to populations, for example, African Americans, in terms of really defining their experience? So I kind of proposed just some very minor modifications in red here. So moving from just not only an unpleasant sensory and emotional experience, but a socio-emotional experience associated with or resembling that associated with actual or potential tissue damage and epigenetic alterations. Because that aspect of history and how transgenerationally it has impacted African Americans is really important. I'm gonna skip this slide and leave with this. So more, I guess, on the treatment/management approach. When we think about one size does not fit all, we have to think about how do we affirm people's identities in their fullness while making sure that they receive the best, most appropriate, evidence-based, timely care. And so pain-affirming care is a new approach that I'm kind of developing It's a non-judgmental approach that goes beyond just accepting and believing a patient's report of pain, but it affirms the patient's identity in their fullness. It validates their lived experience of pain. It respects their natural or preferred way of presenting with pain, and it manages pain using timely, personalized strategies based on evidence and equitable policies. So with that, I'm going to say thank you. I, again, apologize for being super late, but if you have questions, I'm here to answer.
Today I'm going to be presenting on a study that's currently, I want to say in the works, but I think we're pretty much in the final stages now. This is coming from the COPE-2 study, which focuses on chronic pain and marginalization, specifically during the time of pandemic, of which Fiona Webster is the director, principal investigator of that particular study. So in its earlier phases, the COVID-19 pandemic was deemed a crisis that created extraordinary challenges, uncertainties, and fears for most Canadians. From this stem narratives of a shared experience of crisis, but this was not always the case. The pandemic laid bare the inequities underlying our health and social systems, and it's argued in the literature that responses to the pandemic further exacerbated these inequities. Furthermore, pandemic-related risks and experiences were not shared equally. Responses affected people in gendered, racialized, and classed ways, and was and continues to be deeply rooted in inequitable economic and political systems. So people living with chronic pain during the pandemic faced additional layers of complexity to their daily lives, like increased risks of severe COVID-19 complications and restricted access to medical care, pain medications, or alternative therapies. These experiences, in addition to the reduced physical activity and increased stress, anxiety, and uncertainty that this time of turbulence often entailed, affected the onset and management of chronic pain. For those living with chronic pain and who are also subjected to marginalization, these pandemic-related challenges occurred within contexts that were already defined by struggle. We know of the notable presence of chronic pain among marginalized populations. For Wallace and colleagues, the injustices that define marginalization are very much linked to pain, thereby making chronic pain not simply a health issue, but an issue of equity and social justice. As they advance, chronic pain is bound up with social locations, identities, experiences of violence, discrimination, stigma and dismissal, mental health issues, and experiences of inadequate and ineffective health care, along with the impacts of these intersecting experiences, specifically on employment, income, and social lives. So to better understand the experiences of people living with chronic pain and marginalization during the pandemic, we utilize key tenets of the sociological approach of institutional ethnography, or IE, which allowed us to begin in people's standpoint to explore how their experiences are socially coordinated with the work of others. A key component of IE entails describing what people specifically do as they go about their daily lives. These doings are referred to as work, and this is a concept that refers to the time, effort, and expertise involved in daily tasks. We focused on the work of people with chronic pain during the coronavirus pandemic who also struggle with systemic and structural marginalization. With marginalization understood as a sweeping process of oppression and domination, we focused specifically on people living with poverty. As an IE study, we also looked for disjunctures or contradictions between how officially stated things are thought to work or happen and how they actually work or happen in everyday lives and doings of individuals. In our study, the disjuncture between what is generally considered shared experience and what actually happens in practice for those who live with poverty and chronic pain during the pandemic was noted in the stories shared with us by participants. This disjuncture illuminates how authoritative discourses, in this case of crisis, can displace descriptions that are based on standpoint or lived experience. So in addition to IE, this paper is inspired by the concept of chronic struggle, which centers upon social and structural inequities within contexts of chronic pain and marginalization. The concept highlights chronic pain as one additional difficulty in a life that is always already defined by health and social complexities. As argued by Webster and colleagues, chronic struggle provides the conceptual space to explicate the enormous work involved in managing lives beset by chronic pain, mental illnesses, trauma, addictions, and/or poverty within systems that regularly delegitimize or stigmatize. In our effort to explicate experiences of chronic pain and marginalization during the time of pandemic, this concept foregrounds how pre-existing knots of struggle inform experience. So when it comes to methods, IE makes use of various qualitative methods, but due to pandemic restrictions, we relied on phone interviews. Throughout these interviews, we focus on people's everyday experiences of negotiating pandemic and pre-pandemic life and the work that goes into living with chronic pain and marginalization. Participants resided in Canada, were over the age of 18, spoke fluent English, and identified as living with chronic pain, and also consider themselves as facing economic hardship, which we phrased as struggling to make ends meet. We interviewed 8 participants between June of 2020 and November 2021, with each interview lasting approximately 60 to 90 minutes, and we conducted follow-up interviews with 3 participants in June of 2023. We indexed the data to capture aspects of the interview data that were relevant to the research objectives. Indexing is an analytical strategy in IE that organizes the data in ways that keep the institution in view and describe what people do and know. It assists in formulating a question that guides the analysis and is developed based on identifying disjunctures that are evident in people's accounts. So when it comes to our findings, we organize them around the ways in which people described their everyday experiences of living with chronic pain and struggling to make ends meet through the following topics. So the first is the pandemic as a source of temporary relief from pre-existing struggles. So here, temporary relief came in the form of physical distancing, whereby folks who felt such pandemic-related measures, they felt that it assisted their need to not always meet specific social obligations, often as a result of their pain. And it also came in the form of emergency financial assistance provided by the government, with one participant sharing that they, in fact, quote-unquote, reap the benefits for their rehabilitation and recovery. The second is the pandemic as one additional and unexceptional struggle. So for the people we spoke with, they described the pandemic and its restrictions and social changes not as a significant crisis in their lives, but rather as one additional burden to navigate within lives already defined by challenge and struggle. So Lisa, one of our participants, for example, in describing the challenges that she was facing during that time, she didn't really focus on the pandemic at all, but instead on her experiences of housing precarity. And lastly, we have the topic of learned resourcefulness in the face of a public health crisis. So here, participants spoke of how the challenges they faced from living within constricted contexts primed them to navigate pandemic restrictions, highlighting how the emergency of the pandemic approximated the emergencies and struggles that people living with chronic pain and poverty face daily. So overall, we were made aware of a disjuncture of crisis during the pandemic between official accounts and everyday accounts, in the sense that crisis is not and should not be understood simply as a rupture, but as persistent. Through our approach, what was made visible were lives of persistent crises that not only inform experience, but also adds nuance to the variability of experience and suggests a shift in how we can and should begin to understand lived experience among people living with chronic pain and marginalization. So here, official notions of crisis are unsettled in diverse, unexpected, and competing ways. So to be sure, crisis typically refers to a claim of urgency employed to characterize a set of contingencies that, taken together, are assumed to pose an immediate threat. In lives that are always already defined by chronic struggle, however, the notion and experience of crisis is altered. So here, crisis is not a temporary abnormality related to traumatic events, but plays a very real role as a constant. And I think another key takeaway of this work is the issue surrounding problems of knowing, being told one thing, but in fact knowing otherwise on the basis of personal experience. And it's through knowing otherwise, as shared by people living with chronic pain and poverty, that the possibility of transformation and or the permanence of other ways of being, living, knowing, and supporting can become apparent. So overall, as an IE study, disjuncture, we argue, calls attention to the inadequacy of both institutional discourses and responses. By speaking with people living with chronic pain and marginalization, we see how words, language, and discourses can assemble the world in ways that disregard particularities. It is where contrasting knowledges and language meet that requires greater attention, including within the chronic pain scholarship. And this is my list of references, and that's it. Thank you.